Good morning, everyone. This is the first lecture of the Endocrine Pathology series. It probably will be around 6 lectures discussing various subjects in endocrine pathology. Today we'll be discussing the first subject, which is pituitary gland diseases. As you might remember, cells in the human body are able to produce molecules that either work on the cell itself in an autocrine fashion, or cells in the immediate vicinity in a paracrine fashion, or like in the endocrine system, which is called the endocrine, meaning it works in distant locations. These hormones are usually transported through the blood, and they exert their effect through either binding to receptors on the surface or inside of the cell, whether on the nucleus or in the cytoplasm. Examples of nuclear receptors, hormones that utilize nuclear receptors include estrogen receptor, progesterone receptor, and thyroxine. Once the exerted effect is achieved, a negative feedback goes back to the source of the hormone. For example, if there is a need for, let's say, growth hormone for growth of various organs in the body, if that growth is achieved, then a signal goes back to the pituitary saying, enough of this growth hormone, we had enough, and that's what's called feedback inhibition. Diseases of the endocrine system carry a similar fingerprint. They are a result of either overproduction of the hormone, underproduction of the hormone, or mass lesions in that organ. Specifically, this mass could be a benign tumor or a malignant tumor. Also, it could be a hyperplasia. The pituitary gland is a small organ located in the base of the brain in the confines of the sella turcica. Anatomically, it has two components, the anterior pituitary and the posterior pituitary. It's connected to the hypothalamus through the stalk. The anterior pituitary is composed of epithelial cells that secrete several hormones, and the posterior pituitary is composed of modified glial cells and connected through axons to the hypothalamus. This is a histologic image of the pituitary gland. There are 3 cell types: basophilic cells, eosinophilic cells, and non-staining cells. The hormones that are secreted from the pituitary gland are under the effect of hormones from the hypothalamus. There are 6 hormones that are secreted from the anterior pituitary, namely TSH, thyroid stimulating hormone, prolactin, ACTH, which stands for adrenocorticotroph hormone, growth hormone, follicular stimulating hormone, and luteinizing hormone. All of these are under direct influence of the hypothalamus, and the signals coming from the hypothalamus are all stimulatory, with the exception of dopamine, which inhibits the secretion of prolactin, and somatostatin, which inhibits the secretion of growth hormone. Like other endocrine organs, symptoms and signs of pituitary disease can be grouped into those related to hyperfunctioning of the pituitary or hyperpituitarism, hypopituitarism, or mass effect. Hyperpituitarism results from excess secretion of typically one hormone and is most commonly caused by adenomas. Other causes include hyperplasia and the extremely rare condition of carcinoma. Pituitary carcinoma is a known disease, but it's really rare. Adenoma is the most common cause. Hypopituitarism, on the other hand, is the exact opposite of that. It results from a destructive process of the pituitary gland, for example, ischemic injury, surgery, radiation, inflammatory reactions such as granulomas. Mycobacterium tuberculosis could sometimes result in destruction of the pituitary gland. And some non-functional adenomas could cause compression, atrophy of the surrounding pituitary gland, resulting in decrease in the production of hormones, with the end result of hypopituitarism. There's a one condition that's worth mentioning, it's called Sheehan syndrome. Uh, it is basically ischemic injury to the pituitary gland in the immediate postpartum period. Because during pregnancy, the pituitary gland enlarges, most likely because of the increase in the size and number of prolactin producing cells. This enlargement of the pituitary gland during pregnancy is not met with increase in the vascularity, which makes the pituitary gland prone for ischemic injury. Now, if during delivery, for some reason, hemorrhage occurs, um, uterine or vaginal excessive hemorrhage, this will result in this might result in ischemia, and it in turn could result in hypopituitarism. Mass effect is another representation of pituitary diseases. Radiographically, the sella seems expanded. The bone surrounding the sella turcica or forming the sella turcica is eroded, and the soft tissue at the roof of the sella turcica, named the diaphragmacella, might be disrupted. If the mass is big enough, it can cause compression of the optic chiasm. Optic chiasm, if you remember, is the X-shaped structure resulting from crossing of both optic nerves. The compression of the optic chiasm results in a characteristic visual loss, specifically bitemporal hemianopia, in which the patient loses the ability to see at the peripheral or lateral or temporal uh, parts of the visual field. If the mass is affecting the ventricular system of the brain, this might result in increased intracranial pressure. Adenomas that invade through the brain parenchyma might result in seizures or cranial nerve palsy. Pituitary apoplexy is one of the few neurosurgical emergencies related to the pituitary gland. Apoplexy basically is hemorrhage and rapid expansion of the pituitary gland by the hemorrhage. This hemorrhage might be fast enough to affect the brain structure surrounding the pituitary gland, and this could result in death. Once again, it's a very important emergency. Let's discuss further hyperpituitarism. The most common cause, as discussed previously, is adenoma. Other causes include hyperplasia, carcinoma, extrapituitary causes, and hypothalamic disorders. Extrapituitary causes include diseases, specifically cancer, in which there is a secretion by the tumor cells of a material that is similar physiologically to the pituitary hormones. This table summarizes the various types of adenomas resulting, or diseases that result in hyperfunctioning pituitary gland. And depending on the cell type, the hormone type will be decided. For example, if the corticotroph cells are adenomatous, then the secreted hormone will be ACTH, and the disease associated with it is Cushing syndrome. Somatotrophes will secrete growth hormone, and the disease is called gigantism in children and acromegaly in adults. Lactotroph secretes prolactin. This results in galactorrhea and amenorrhea in females, in addition to sexual dysfunction and infertility. Mammosomatotrope, this is a characteristic type of pituitary tumors in which two hormones are being secreted, namely prolactin and growth hormone. Various combinations of various hormones can be secreted together. However, prolactin and growth hormone are the most common combination. Thyrotroph secretes TSH, which results in hyperthyroidism. And gonadotroph hypersecrete FSH or LH, and this results in hypogonadism, but most of the time mass effect, because most of the time these are not very functional, and if they are, they do not cause clinically significant syndrome secondary to the hormone. That's why when it comes to LH and FSH secreting adenomas, the most common presentation is actually related to the mass effect, not the hormone itself. The pituitary adenomas could be functional or non-functional. They could secrete single hormone or more, and as we mentioned, the most common combination is somatotroph and growth hormone and prolactin. The non-functional present later because they do not secrete hormones, so they are allowed enough time to be big enough. And this mass effect could actually affect the other healthy cells of the pituitary gland, resulting in hypopituitarism. Most of these cases are sporadic, only 5% are familial. And grossly, the adenomas can be divided into macro and microadenomas depending on the size. The pathogenesis of adenoma is related to mutations in the G protein sequence. You probably remember the G protein are membranous protein that bind to ligands. In this case, or normally, the hormones coming from the hypothalamus. Now, binding of the hormones from the hypothalamus to these receptors on the membranes results in activation of the second messenger, which is cyclic AMB. The G protein is part of this equation, and the activation of this sequence is usually transient because of the GTBase activity of GTB. Now, if mutation happens in the alpha subunit of the G protein, which is one of the most common mutations uh, affecting the pituitary gland, this results in constitutive activity of the G protein without the need for a ligand. This results in unchecked proliferation and the growth of these cells. 40% of growth hormone or somatotrope adenomas actually have mutations in the GNAS gene. This is the gene that produces the alpha subunit of the G protein. As mentioned previously, most cases are sporadic, and familial cases represent around 5% of the cases. In this case, certain genes are affected, for example, MEN1, cyclin-dependent kinase 1B, PRKARIA, and AIP. TP53 mutation, which is, have you probably seen by now, is common among many tumors. If it's present, it denotes an aggressive behavior of the tumor. This is a microscopic picture of a pituitary adenoma. Notice the large mass at the base of the skull actually encroaching and compressing the lateral ventricle. This is a histologic image. If you compare this one to the one by the beginning of this lecture, notice that this tumor is composed of only one cell type. All of them are eosinophilic. There is no basophilic or non-staining cells. This is a characteristic of any tumor. It's composed of only one cell type. The word or the phrase atypical adenoma is used to describe tumors with significant pleomorphism and brisk mitotic activity, typically associated again with TP53 mutation, and they have a poor prognosis. The most common subtype of hyperpituitary adenomas is actually prolactinoma, a pituitary adenoma that secretes prolactin. It's the most common type of functioning adenomas, and it can be variable in size. Due to the secretion of above normal amounts of prolactin, hyperprolactinemia is the result, and the clinical manifestations of hyperprolactinemia is amenorrhea, galactorrhea, loss of libido, and infertility. Due to the specific nature of these manifestations, the effect of prolactinoma tends to be discovered early in young women or women in their reproductive age, as opposed to men and older women, in which the manifestations are subtle and the tumors can attain a large size before being discovered. Other causes of hyperprolactinemia include pregnancy, high-dose estrogen therapy, renal failure, hypothyroidism, hypothalamic lesions, dopamine-inhibiting drugs like risperidone, and stalk effect, meaning a mass that compresses the stalk, resulting in absence of the inhibitory signal, which is dopamine from the hypothalamus, and then prolactin goes unchecked, resulting in hyperprolactinemia. However, all of these causes typically result in prolactin levels that are mildly elevated. And if the level is more than 200, it's more likely than not that it's caused by a prolactinoma or adenoma. The second type of hyperfunctioning pituitary adenomas is the growth hormone producing, also called somatotroph cell adenomas. This is the second most common type of a functional pituitary adenoma. What happens is when the growth hormone is being secreted in an excessive amount, it results in stimulation of a protein in the liver called insulin-like growth factor, also known as somatotropes C. This is secreted from the liver in response to the growth factor from the pituitary gland. The increase in the insulin-like growth factor 1 results in many clinical manifestations. In children, these are called gigantism, and in adults, they are called acromegaly. Just for as an example of the real-life clinical manifestations on a pituitary by a pituitary growth hormone adenoma. This is an image of a obviously young gentleman. Uh, he seems kind of normal. This is another gentleman who is affected by pituitary adenoma. Notice the big mandible. Notice the protruding eyes, ears, and the big nose. This image is the same gentleman that we saw previously after being affected by a pituitary adenoma with growth hormone excess secretion. In addition to the growth of the limbs, thickness of the bones, and protruding mandibles, noses, and ears, there are other manifestations, including abnormal glucose tolerance and diabetes, generalized muscle weakness, hypertension, arthritis, osteoporosis, and congestive heart failure. Another type of pituitary adenoma is the one that secretes ACTH or adrenocorticotropic hormone. Most of these are microadenomas. The differentiation between adenoma and microadenoma, between microadenoma and macroadenoma is a function of the size. Any adenoma that's below 1 centimeter in diameter is called microadenoma. Anything more than that is called macroadenoma. So when it comes to corticotroph cell adenomas, most of them are small. They stain positively for PAS, which is a stain specific for binding proteins that are rich in sugar. And the cytoplasm of these cells is rich in glycogenated or proteins that are rich in glucose. That's why they stain positive. They result in Cushing syndrome, which is a constellation of signs and symptoms related to increased cortisone. And another syndrome is called Nelson syndrome. We will discuss these shortly. Now, Cushing syndrome. This is a schematic presentation of Cushing syndrome. These patients are characterized by thin skin, red cheeks, moon face. Since they have thin skin, they are easily bruisable. They have striae on the abdominal wall and the thighs. They have thin arms but big tummy, so they have central obesity with thin limbs. This is a common manifestation of Cushing syndrome. Nelson syndrome results from the surgical removal of the adrenal gland as a treatment of Cushing syndrome. This will induce the loss of the inhibitory effect of the adrenal corticosteroids on the pituitary adenoma. As we previously mentioned, the concept of negative feedback is when the hormone that's induced by the pituitary goes back to the pituitary gland and sends a signal saying that we don't need we don't need more stimulation. Now, since the adrenal gland is removed, that negative feedback that the cortisone, which is secreted by the adrenal gland, exerts on the pituitary gland is lost. Since this negative feedback is lost, whatever microadenoma present in the pituitary will grow, it will enlarge, and secrete more ACTH. Now, since we don't have an adrenal gland, there will be no signs of hypercortisolism. Actually, there will be hypocortisolism because, again, we don't have an adrenal gland. We will have a mass effect because of the enlarging ACTH-producing adenoma. and some hyperpigmentation, because ACTH produced by these microadenomas will have a stimulatory effect on some molecules in the skin cells called the melanocytes. Gonadotroph releasing adenomas. These are adenomas that either secrete FSH or LH, most commonly actually follicular stimulating hormone, or FSH. Since these hormones do not have a great effect clinically by themselves, these adenomas tend to be late when they're discovered and with large sizes. TSH producing pituitary adenomas are very rare, only 1% of the adenomas, and can result in hyperthyroidism because, as you probably know, TSH goes to the thyroid gland. It has a stimulatory effect on the thyroid follicular cells. This will in turn result in the secretion of T3 and T4, resulting in hyperthyroidism. 25% of the pituitary adenomas are non-functional, meaning they do not secrete clinically significant amounts of hormones, and they present as a mass effect, as we mentioned previously. Carcinoma of the pituitary is exceedingly rare. It has a local invasion to the surrounding tissue and invariably demonstrate distant metastases to other organs. Hypopituitarism reflects the decrease in the function of the pituitary adenoma. This occurs when there is a loss of the pituitary cells of 75% or more of those cells for hypopituitarism to manifest. These could be acquired or congenital. They can also result from hypothalamic lesions affecting the delivery of signals from the hypothalamus to the pituitary gland. Specifically, when there is a hypofunctioning of the anterior pituitary associated with failure of the posterior pituitary, meaning failure of secretion of the posterior pituitary gland hormones, namely oxytocin and antidiuretic hormone, resulting in diabetes insipidus, this reflects that the most likely origin of the disease is the hypothalamus. The pituitary causes of hypopituitarism include non-functioning adenomas. As you mentioned previously, those adenomas can attain large sizes and compress the healthy epithelial cells around them, resulting in decrease in their function. Ischemia, as in Sheehan syndrome, this is a complication of delivery and pregnancy because pituitary gland attains large sizes during pregnancy without accompanying vascular supply. And if ischemia occurs or hemorrhage occurs due to whatever reason during delivery, this might put the pituitary into jeopardy because of the decreased blood supply. Ablation by surgery or radiation. Other infiltrative disorders such as sarcoidosis, tuberculosis, or metastatic carcinoma, all of these could result in hypopituitarism. Clinical manifestations depend on the deficient hormone, failure to thrive if the major hormone that is being deprived is a growth hormone, amenorrhea and infertility in cases of prolactinoma in cases of a decrease in prolactin or decrease in FSH or LH, hypothyroidism if there is decrease in TSH, hypoadrenalism in case there is decrease in ACTH, and hypopigmentation because again ACTH results in stimulation of melanocytes. Posterior pituitary syndromes. The posterior pituitary secretes oxytocin and ADH, antidiuretic hormone. These come from the hypothalamus into the posterior pituitary gland. You probably remember that oxytocin has certain functions related to nursing mothers. Some people call it the love hormone. However, there is no clinical significance for low levels of oxytocin. Antidiuretic hormone is the clinically important posterior pituitary hormone. The diseases related to ADH are diabetes insipidus in cases of low ADH and secretion of inappropriately high ADH in cases of high ADH. Quick reminder of the role of antidiuretic hormone. Let's assume a scenario in which a person works out and this results in sweating, which results in loss of fluid from the intravascular space. This will be signaled by the hypothalamus. The hypothalamus will send a stimulus to secrete more antidiuretic hormone. ADH in turn will go to the kidney and act on the renal tubules to prevent loss of water into urine and encourage reabsorption of water into the plasma. This will result in restoring the plasma volume. So what happens in diabetes insipidus is that either the the hypothalamus and the posterior pituitary are not secreting enough antidiuretic hormone, which means that even in cases of shrinkage of the plasma volume, the kidney is not able to retain fluid. Hence, the patient feels thirst all the time and they drink a lot of water. Diabetes insipidus can be caused by head trauma, inflammatory conditions, neoplasia, or idiopathic. Anything that results in ablation of the posterior pituitary or the hypothalamus could result in diabetes insipidus. Diabetes insipidus could be central, meaning if the cause is due to hypothalamic or pituitary disease, or nephrogenic, in which there is a normal amount of ADH secreted by the pituitary, however, the renal tubules in the kidney are not responsive. Clinical manifestations include a large volume of urine because the kidney cannot retain fluid, low specific gravity of urine because water is being secreted more than sodium. Since the blood is losing fluid, there would be high serum sodium and high serum osmolarity. This would be associated with thirst and polydipsia, meaning the patient drinks large amounts of water. Finally, the syndrome of inappropriate ADH secretion. This results in increased resorption of water from the kidneys, and it's most commonly caused by malignant lung tumors, specifically a tumor called small cell carcinoma of the lung. This was the first lecture of the endocrine system. For this system, I strongly suggest that you guys read chapter 20 from Robbins' Basic Pathology, the 10th edition. This is your reference, and I strongly suggest that you read it thoroughly. If you have any questions related to the material, please do not hesitate to ask. Please stay safe and healthy. Talk to you later.